Good afternoon. I am Clara Perret, geriatrician from Argentina, and I will coordinate this session about the best oral presentations number 3. The first speaker will be Dr. Karen Buyens. She's a senior lecturer in criminology within the Department of Social Work and Criminology in the University of Pretoria, South Africa, and she will talk about the vulnerability of older male offenders in South African prisons, implications for correctional services and policy. The second speaker will be Dr. Laura Bottini from Argentina. She's a master in gerontology, social services management, and residence planning, and she will speak about from unwanted loneliness to rewarding relationships prepared by the working team of the Asociación Adulto Feliz Lima, Peru. The third speaker will be Dr. Gloria Gutman. She founded the Gerontology Research Center and Department of Gerontology at Simon Fraser University, Vancouver, Canada, where she is currently Professor Emerita, and she will speak about a confluence of cultures, advanced care planning in long-term care settings. The fourth speaker will be Ms. Clara Heinrich. She is a pharmacist and PhD scholar with the School of Pharmacy at University College Cork, Ireland, and she will talk about barriers and enablers to the prescribing in long-term care, a qualitative investigation into the opinions of healthcare professionals in Ireland. The fifth speaker will be Nurse Hanako Numata. She's a doctoral student in the University of Tokyo Division of Health Sciences and Nursing, and she will speak about the association between pain care process and pain outcome among older people receiving home care, a quality indicator development project. The sixth speaker will be Dr. Kevin O'Malley. He is a medical registrar working in the area of acute geriatric medicine and stroke at Galway University Hospital in Ireland, and he will talk about the institutional erasure of LGBTQ+ older persons on the websites of nursing homes and long-term care facilities in Ireland. The seventh speaker will be Dr. Bruno Rota. He's a pharmacist at the clinical pharmacy section of the Hospital de Clínicos de Porto Alegre, accompanying the geriatrics teams. He will talk about the association between high anticholinergic risk drugs with incident delirium in hospitalized elderly aged 75 years or older in a hospital in Brazil. And the eighth and last speaker will be the nurse Aruno Suzuki. She's a doctoral student in the Division of Health Sciences and Nursing in the Graduate School of Medicine, University of Tokyo, Japan. She will speak about the effectiveness of a dementia educational program using virtual reality technology for the general public, a randomized controlled trial. Let's start the session. I invite you to listen to these interesting presentations.
I'm Karen Buyens, and I will be presenting a paper on the vulnerability of older male offenders in South African prisons, implications for correctional services and policy. Internationally, there is a steady rise in the older adult inmate population, also known as the graying offender population. Furthermore, older inmates are regarded as the fastest growing prison cohort. It is estimated that by the year 2030, more than 1/3 of the prison population will comprise of inmates who are older than 50 years. With the increase in the older adult offender population, it has become recognized that the older inmate should be considered a disadvantaged and vulnerable group due to physical and mental health issues, the possibility of victimization, the prison environment, and issues relating to release, reintegration, and dying in prison. To date, the biopsychosocial circumstances of this offender group has been ignored in South Africa and many other countries in the global south. As such, the goal of this study was to explore and describe the biopsychosocial circumstances of older male inmates incarcerated in South African prisons. A quantitative research approach was followed and a cross-sectional survey design was implemented. Although it is widely argued that older inmates are those aged 50 years and older, the authors targeted sentenced male offenders older than 60 years, and this decision was prompted by the Older Persons Act 13 of 2006, which describes an older person as someone of 60 years and older. Other criteria for inclusion in the study were that respondents did not suffer from any form of dementia and had to be willing to participate in the study. In the end, a total of 88 older offenders incarcerated in 4 South African prisons completed the study. Due to the high rate of illiteracy among the incarcerated, data were collected through face-to-face surveys, where the older sentenced male offenders were interviewed by the authors and their answers were recorded in writing. The self-developed survey covered numerous domains. However, for the presentation, I will only focus on offender vulnerability. Due to the sample size, statistical analysis were limited to descriptive statistics and the calculations of Fisher's exact test for association statistics. Ethical approval was obtained prior to data collection from the tertiary institution the authors are affiliated with and the South African Department of Correctional Services. The pertinent findings of this study as it relates to the vulnerability of older incarcerated male offenders will now be shared. As expected when surveying older persons, the majority of respondents indicated that they experienced physical health problems, with many suffering from more than one medical condition. The frequency of medical conditions disclosed by the respondents were as follows: hypertension, eye problems, arthritis, diabetes, heart problems, high cholesterol, prostate problems, HIV, asthma, and TB. At the time of the survey, 67 respondents were taking medication for their particular health problems. 41 older inmates indicated that they use glasses. 11 use dentures. 3 offenders make use of hearing aids. 2 offenders use a cane, and 1 offender was in a wheelchair. The overwhelming majority of respondents indicated that they have never been diagnosed or treated by a psychologist or a psychiatrist. However, of the 23 respondents who have been diagnosed or treated for a mental disorder, the majority reported depression and a dual diagnosis of depression and anxiety disorder. As a mental disorder may put someone at risk for suicide, the study explored whether the respondents ever considered committing suicide. 23 confirmed that they considered suicide, while 2 respondents declared that they have also attempted suicide. Due to the physical infrastructure of South African prisons, the respondents experienced various institutional challenges, including waiting in line for food, difficulty in climbing stairs, and difficulty getting on or off their beds, especially when expected to sleep on the top bed of a double bunk bed. Older inmates are regarded as vulnerable. Hence, the authors also endeavored to determine their risk of victimization. The findings of the study showed that 41 respondents were victimized and that they were more likely to be the victims of theft and verbal assault by fellow inmates. Older adult offenders in the current study who were physically assaulted indicated that the alleged offender was a younger inmate, and this is referred to as the wolf-prey syndrome. And reasons for being targeted by younger inmates may be their poor health, as well as their lowest social standing in prison. Only 1 respondent indicated that he was sexually assaulted by another inmate. As older offenders have a more difficult adjustment to community reintegration than younger offenders, contact with significant others are important during incarceration, as it may help with their reintegration after release. It was encouraging that the majority of respondents from this study confirmed that they kept in contact with family members and friends. The nature of the contact was either through visits by family and friends to the prison or telephone calls made to significant others. Due to physical ailments and the increased age of some of the older inmates, it was not surprising that 60% of respondents indicated that they were afraid of dying in prison. However, dying inside prison is a specific fear among older offenders, and death anxiety is more commonly reported by older inmates than younger inmates. In conclusion, the findings of this study support the notion that South African older male offenders are indeed a vulnerable group. Not only do they suffer from physical and mental health conditions, they also have to cope with institutional challenges and victimization. Given the fact that older inmates describe being victimized by younger inmates with whom they either share a cell or they interact during their prison life, it is recommended that the Department of Correctional Services consider age segregation. Furthermore, correctional staff should receive specialized training in the handling of older inmates and their unique needs. Finally, the authors propose that in order to address the vulnerability, older inmates should undergo individualized age-based needs assessment informed by appropriate policy and correctional protocols. During the initial assessment, particular attention should be paid to the physical, social, and psychological conditions, but also the needs of the older inmate. Thank you for the opportunity to share our research.
Bueno, buenos días a todos. En principio, agradecer enormemente tanto a la IAGG como a las autoridades argentinas, a las instituciones representantes de este mundial, tanto la Asociación Gerontológica Argentina como la Sociedad Argentina de Geriatría y Gerontología, que bueno, que tan honrosamente han sabido llevar adelante estos momentos difíciles y que hoy estemos de nuevo todos aquí comprometidos por los derechos y la calidad de vida de nuestros adultos mayores. En este caso, estoy muy honrada y agradezco también a la Asociación Adulto Feliz que me hayan seleccionado para ser la representante en esta presentación, valga la redundancia, y traerles este tema tan interesante que es de la soledad no deseada, que es la pandemia del siglo XXI realmente, y intentar llegar a los vínculos gratificantes. Aquí está el team de la Asociación Adulto Feliz, que luego lo podrán ver con más detalle. Y como introducción veremos que la exposición constituye fundamentalmente una aproximación a cómo se vive la soledad no deseada en el Perú y cómo se experimentó durante la pandemia, investigación que llevamos a cabo entre los años 20 y 22 en la ciudad de Lima, tomando a todos los niveles socioeconómicos y tanto a hombres como a mujeres, y también a tomar fuentes secundarias sobre soledad, resiliencia y esperanza. En cuanto a la soledad no deseada, diremos que es una soledad impuesta, que implica, por supuesto, una sensación totalmente subjetiva de discrepancia entre las relaciones sociales que tiene una persona y las que querría tener, que afecta mayoritariamente a la población adulta mayor, si bien a ambos afecta enormemente, pero fundamentalmente a las mujeres, siendo las más afectadas de 1 a 4, con causales para ambos grupos de género, tanto femenino como masculino, el aumento de los hogares unipersonales, el descenso de la natalidad, el empleo y la desnaturalización del trabajo como fuente de encuentros, cosa que antes ocurría normalmente y que se ha ido modificando con el correr del tiempo, y por supuesto sabemos que tanto soledad como aislamiento generan modificaciones negativas, tanto en los aspectos físicos como psíquicos, causando resultados que pueden llegar a ser muy graves, como el suicidio y la muerte por enfermedades que, bueno, en esta oportunidad no tenemos forma de poder comentarlo, pero que venimos trabajando en ello hace varios años. Miremos que el Perú no escapa a lo que son las tendencias de un mundo globalizado, con un incremento importante de la esperanza de vida. Las familias también son más cortas, Pero los mayores no suelen vivir solos, cosa que voy a explicar ahora, y comparten los hogares con parte de su familia. Acá tenemos algunas de las estadísticas que solo voy a mencionar, diciendo que la esperanza de vida tiene hoy una edad de 77,4 años, teniendo un 13% aproximado de la salud de la sociedad envejecida, por lo cual se puede considerar un país envejecido, pero lo importante a destacar, porque también se va a mencionar más adelante, es que afiliados a un sistema de pensión formal solo hay un 36% de la población. En cuanto a este título que le pusimos a esta filmina, que tiene que ver con estar juntos sin compartir, diremos que a pesar de la convivencia en familia, hay un gran edadismo, la experiencia de soledad se encuentra más matizada, diría, que a la carencia de contactos o de proximidad física, que en estos casos muchas veces se tiene, por lo que es el entorno cultural y de educación. Dado que hay adultos mayores de distintas regiones del Perú, que son quechua hablantes, y muchos de sus hijos, y sobre todo de sus nietos, prácticamente no los comprenden, ni han podido hacer hasta ahora este intercambio intergeneracional que sería tan importante. Por lo tanto, hay un proceso de alfabetización digital que por un lado se dio, que aquellos adultos mayores que pudieron acceder a él lo hicieron, y que por supuesto hizo que se achicaran las brechas en la manera de intercomunicarse con otros, pero que hay que estar muy atentos a esto, porque por otro lado puede llegar a producir lo que se denomina un gran aislamiento físico, un aislamiento de lo que es el contacto, el abrazo, esta cotidianeidad que se necesita, por lo cual hay un efecto paradojal, ¿no?, entre acceder a los medios informáticos, pero luego la posibilidad o la imposibilidad, mejor dicho, de poder estar con el contacto físico tan necesario para todos, y especialmente para los adultos mayores. En cuanto al impacto diferenciado de la soledad, que es esta filmina que presentamos, diré que lo que resultó de los estudios realizados en los focus group, que fue lo que prioritariamente hicimos durante estos 2 años de pandemia, podemos decir que a mejor condición económica el acceso a servicios y a espacios de interacción social es mayor y es satisfactoria, así como también a lugares recreativos, a espacios más cómodos, a viajes, a otro tipo de interacciones sociales. Por lo tanto, podremos decir que objetivamente hablando, habría una menor soledad no deseada o impuesta, siendo que en los grupos de menor capacidad económica, que son muy notorias estas diferencias socioeconómicas en el Perú, viven en condiciones de hacinamiento e incomodidad, con pocos espacios públicos a donde acceder, y que mayoritariamente han sido cerrados, y la mayoría no han podido abrir luego de la pandemia, y las relaciones intergeneracionales en el mismo hogar, que al principio parecían muy favorecidas, resultaron ser fuertemente afectadas por estas distancias culturales que antes mencioné. En cuanto a la vida familiar y las personas adultas mayores en el Perú, diría que viven en familias, pero que fundamentalmente, así como el adulto mayor está integrado a la familia, y acá como lo vemos en esta hermosa foto, muchas veces el abuelo cuida de sus nietos, y se integra también lo que es el aporte, así sea muy magro, pero como comenté, hay una muy poca cantidad de gente que recibe un haber jubilatorio digno, muchos más vale tienen jubilaciones o ingresos informales, que lo hacen trabajando todo el tiempo que pueden, por lo cual también esto colabora en lo que es el ingreso familiar habitual, digamos, de toda la familia en su conjunto. Y cuando el adulto mayor comienza a tener algunas necesidades, de manera informal, los familiares son los que se transforman en sus cuidadores de la mejor manera que pueden, porque el sistema de salud es muy precario. Y este es uno de los temas que hay que tratar de mejorar, y por eso lo estamos haciendo público. En cuanto a la casa de reposo, la opción es prácticamente nula, porque hay muy pocos establecimientos acreditados, no hay leyes regulatorias al respecto, como en otros países, y además está mal visto, está tanto cultural como afectivamente mal visto que ingrese a casas de reposo, como ella menciona, que serían nuestras instituciones geriátricas, los adultos mayores. En cuanto a la pandemia y la soledad, toda la incertidumbre de las fases iniciales de la pandemia fueron mitigadas porque hubo una fuerte intervención de parte directa de la Presidencia de la República, con mensajes prácticamente cotidianos que hizo que, junto con adelantos de pensiones y otras ayudas, de alguna manera suavizaran el impacto de la pérdida. Pero luego, cuando el tiempo fue pasando y la pandemia se fue estirando y se fue alargando, dio paso a sensaciones mucho más desagradables y se rechazaron con mucho más énfasis todas las situaciones de aislamiento. ¿Qué quiere decir esto de normalidad de la muerte? En realidad se refiere a la naturalización de la muerte, porque hubo fallecimientos muy importantes en el Perú, mucho más importantes que en otros países de América, y ni que hablar de Europa o del resto del mundo, y se manejó de tal manera, la política pública se administró de tal manera que se naturalizó de alguna manera que los adultos mayores eran aquellos más proclives a fallecer, y que por lo tanto los eventos más dramáticos y los eventos más dolorosos que hicieron a esta imposibilidad de estar juntos, como lo digo ahora en la próxima filmina, como vemos acá todas las fotos de aquellos fallecidos, no solo adultos mayores, quedaron relegados los ámbitos particulares, y esto no se diera demasiado a conocer. Fue muy dura la experiencia de la soledad, sobre todo cuando estos adultos mayores se convertían en pacientes e eran internados en el mejor de los casos. La muerte pareció naturalizarse, pero luego, cuando llegaba a esta dimensión de tanta rapidez y de tanta sorpresa frente a estas situaciones de fallecimiento por situaciones de COVID, la posibilidad de despedida fue tan acotada, o nula, diría más vale, que la intensidad de la soledad, por supuesto, fue mucho mayor, y ambas partes se sintieron absolutamente desprotegidos y aislados, ¿no? Sobre todo para aquel falleciente y para la familia que no pudo despedirse. Por eso hablamos de lo que es una inhibición del afecto, porque lo que ocurrió es que frente a esta incertidumbre del virus y de cómo manejarlo, este fenómeno tan azaroso, tan creciente, que no solo fue parte del Perú, sino de todo el mundo, se produjeron distanciamientos, sedentarismo, y por supuesto que también inhibición de afecto. Las familias dejaron de verse, dejaron de encontrarse, todos fueron elementos propiciadores de la soledad no deseada, ¿no? Y una soledad muy castigada, porque muchos se encontraron muy solos, sin tener a quién recurrir, o viendo de qué manera se arreglaban frente a estas situaciones que les impedía encontrarse desde el afecto y desde otro tipo de necesidades. Sabemos perfectamente que la soledad no se inventó, al contrario, con la pandemia, porque sabemos que es algo que es una crisis y una epidemia, como así se la menciona, del siglo XXI creciente, pero en la medida que todas estas situaciones de pandemia fueron acaeciendo, por supuesto que reforzaron todas estas experiencias de soledad. Ahora, ¿cómo paliarla? Pasé algunas filminas rápidamente, que ustedes luego podrán verlas, con más detenimiento. Yo estoy con el tiempo bastante acotado. Bueno, ¿cómo paliar la soledad? Fundamentalmente la orientamos, de acuerdo a todo lo que observamos luego de haber efectuado estos focus group, a fomentar los vínculos entre los objetivos de las personas, la historia de vida de cada adulto mayor y su calidad subjetiva. Dada estas diferencias que se presentaban en los distintos grupos de adultos mayores que entrevistamos, es que nos dimos cuenta que realmente debe ser una atención focalizada a través de distintos objetivos que ahora voy a plantear para paliar la soledad. Por supuesto, los factores fundamentales a considerar son resiliencia, control percibido, o sea, como cada persona se percibe a sí misma, la esperanza realista y la autoestima. En cuanto a motivar la resiliencia, es un proceso que facilita la identificación de mecanismos personales y sociales, así como el desarrollo de habilidades que ayudan a personas a generar espacios responsables. En realidad tiene que ver con generar oportunidades realistas hacia el futuro, basándose en aquellas experiencias vividas en otros momentos pasados, y que se puedan constatar y traer al aquí y ahora de una manera mucho más dignificada para poder trabajar sobre ellas y poder salir adelante. Otro de los aspectos a tener en cuenta son la esperanza y los vínculos gratificantes, que a esto es a lo que tendemos. Sabemos que el realismo de la esperanza, o sea, ser realistas, teniendo esperanza en un futuro diferente, son los posibilitadores de vínculos gratificantes, se sustentan en experiencias, en el desarrollo humano, en aquellos momentos de desafío y de adversidad, como mencioné anteriormente relativo a la resiliencia, con condiciones personales de autodescubrimiento, con cooperaciones para el desarrollo con otros grupos, y que impidan esto que es el aumento de la soledad no deseada, trabajando hacia motivaciones que apuesten al futuro, pero teniendo sobre todo un compromiso con el presente. La inteligencia emocional, como dice en esta filmina, fomenta el desarrollo de emociones positivas, configura una persona valiosa y segura, que sobre estos aspectos debemos trabajar fundamentalmente, saber apreciar el presente, el aquí y el ahora, ajustándose a cada momento, desarrollando un enfoque optimista, esperanzador, con objetivos y con logros que sean posibles y alcanzables, o sea, que tengan que ver con el aquí y ahora de lo que esta persona está viviendo. Por último, diremos que lo fundamental es la conciencia comunitaria social. ¿Qué quiere decir esto? La importancia de visibilizar el problema, como venimos diciendo ya hace varios años que trabajamos sobre este tema, de convertirlo en una realidad, de dividir las estrategias de los diferentes programas para paliar esta soledad no deseada y sobre todo luego de estos eventos de pandemia, en 4 tipos de funciones fundamentalmente, que son aquellas que aumentan las habilidades sociales, aquellas que están dirigidas a fortalecer el apoyo social, aquellas que aumentan las oportunidades de interacción social y las dirigidas al entrenamiento sociocognitivo. Por supuesto, siempre las más eficaces son aquellas que funcionan de manera grupal, con actividades de apoyo y educativas y que se dirigen a grupos específicos. Bueno, muy agradecidos, esperamos haber colaborado un poquito más para poder sanear a la brevedad posible y poner en la agenda pública esto que es la soledad no deseada, la soledad impuesta, y que genera grandes gastos a todas las naciones, que debe ser abordado para poder resolverlo lo antes posible. Así que muchísimas gracias por haberme escuchado.
Advanced care planning is a process that people use to understand and share their personal values, goals, and preferences about future medical care. While policies of long-term care homes may promote discussions of advanced care planning, often the outcomes differ from what the residents want. We believe that this results from a complex confluence of cultures that are simultaneously at play. This slide shows 4 of the cultures. The study I want to tell you about today used a mixed method approach where we had a brief personal profile questionnaire and then conducted focus groups with 4 groups, 2 in each of 2 long-term care facilities. One of the facilities had a population that was exclusively Chinese. In the other, there were multi-ethnicities reflected. And we talked to the residents and we talked to family members. As well, this is part of a broader study in which we had focus groups with staff. But today our focus is really on ethnicity as a component of culture and on similarities and differences between what we heard from residents and from family members. This slide shows the socio-demographic characteristics of the residents. As you can see, in the multi-ethnic group, 4 out of the 8 were from China. The others were from the United States, Argentina, Fiji, and Japan. In terms of the characteristics of the family members, most of them were children of the residents, and not necessarily of the residents we talked to, but were rather, they had family in that particular home, and it included in this group both males and females, and some who were born in Canada. So in terms of themes, 4 were clear, emerged from our analysis of the transcripts of the care home residents. And as you can see on this slide, they ranged from virtually no discussion of advanced care planning to full discussions and completion of documents. And there was a clear connection in the responses of both the residents and, as you'll see, in the family members between ACP and wills or funeral plans. So the concept of ACP is not one that was clearly understood. At the Chinese home, there was a general reluctance to speak about advanced care planning. In terms of referring to family, in the Chinese home, they were quite clear in expressing the role of family, saying family will take care of you, family knows what to do when the time comes. We got a little more multi-dimensional perspective from the residents at the multicultural home, who said that they recognize that some families really don't want to give up on their loved ones, and that some people really are in the situation of having no family. In terms of relationships with staff, several of the respondents at the Chinese home said staff were really too busy to talk about it, and that they'll just give us the forms when the time comes. The multi-ethnic home residents said that they would talk to the person in charge if they were to become ill, and they were quite comfortable as staff raised the issue of advanced care planning with them. There was some discussion of the quality of life at end of life, and the was more of a focus in the multi-ethnic group on the resident having some say and control of what happened to them at the end of their life. In the case of the families of the care home residents, we also found 4 themes. And the one of the important ones was to say that it's families really do need to think about these things ahead of time. And that at the multi-ethnic home, one of the respondents said we expressed the view that they had wished they'd discussed it more before their mother passed away. So in terms of communicating with family, the people felt that there was a need for involvement in such discussions, and that if every one of the family members were present, then it would resolve some conflicts because they all would hear the same thing and know the views of the residents. So there was, as this slide shows, at the Chinese home, people felt that they were listened to, that given they were the same culture as the staff, that there was accommodation and a recognition of the ethnicity of the clients and of their background. And cultural and religious issues were talked about, as well as the idea of diversity within diversity, that some of the families had been in Canada and were more enculturated to Western culture. So this slide summarizes some of the key themes in the resident focus groups, and this in the family focus groups. So in the end, our conclusion was that there definitely is a cultural influence in long-term care and in the way in which advanced care planning happens or does not. and that we need to recognize that these influences intersect. And we hope that this study will provide a starting point, because there has not been much examination of the relationship between culture and advanced care planning, although people do refer to it.
Welcome attendees of the 22nd World Congress of Gerontology and Geriatrics. My name is Clara Heinrich. I am a pharmacist and PhD researcher from the School of Pharmacy in University College Cork in Ireland. And I would like to thank the event organisers for affording me the opportunity to present findings from our qualitative study titled Barriers and Enablers to Deprescribing in Long-Term Care Facilities, a qualitative investigation into the opinions of healthcare professionals in Ireland. And I'd like to thank my colleagues and supervisors, Drs. Maria Donovan, Suzanne McCarthy, and Sheena McHugh for their support with this project. So similar to global figures, the Irish population is aging, with the percentage of adults aged 65 years or older expected to double by 2051. With an aging population, there's an increased demand for long-term care. So these are settings to support older adult healthcare needs and activities of daily living. In Ireland, the demand rose by nearly 10% alone in 2016, and this demand is projected to further increase by 40 to 45% from 2015 to 2030. So among long-term care residents, the incidence of physical frailty is high, higher than patients in other settings such as primary or secondary care. Increasing age and multimorbidity is associated with polypharmacy, generally considered the use of 5 or more medicines. The incidence of polypharmacy is increasing as older adults are prescribed multiple medications to treat their various comorbidities. And with the physiological changes associated with the aging, medications which were once safe and appropriate may become inappropriate, leading to potentially inappropriate prescribing and subsequent inappropriate polypharmacy, which is of concern. Negative outcomes associated with inappropriate polypharmacy include an increased risk of adverse drug reactions, health decline, hospitalizations, and mortality. So having an understanding of the population and the problems associated with inappropriate medication, what can we do about it? So a potential solution is deprescribing. This describes the systematic process of discontinuing a medication where the harm outweighs the benefit and includes stopping a drug, tapering the dose, or switching to a safer alternative. Deprescribing studies have been conducted in various settings, and they've also been conducted for various conditions and different patient cohorts. And within these studies, various different interventions to promote deprescribing have been used, such as patient education, electronic decision support tools for healthcare professionals to flag potential targets for deprescribing, and medication review led by various healthcare professionals, such as doctors, pharmacists, to identify potentially inappropriate medications to deprescribe. Focusing on long-term care, the documented benefits of deprescribing include improved medication adherence, quality of life, reduced time spent on drug rounds, reduced falls, PIM use, and mortality. So a brief overview of long-term care in Ireland. Long-term care is mostly divided into 2 different organisational structures. So firstly, the public system, where it's state funded and nurses and nursing staff are state employed. Here we have one general practitioner, a role similar to a primary care physician or family physician, who acts as the medical officer for the site, with one pharmacy supplying pharmaceutical care. The second system is a private structure, not state funded, and is responsible for about 75% of the long-term care beds in Ireland. Here, residents keep their original doctor, and generally one pharmacy supplies pharmaceutical care. In all sectors, only nurses and nursing staff are on site full-time. Geriatricians and psychiatrists may visit to review residents on site or else at an outpatient setting, and general practitioners and pharmacists visit the setting to provide their services, as there's no full-time doctor or pharmacist on site. To offer insight into the regulation of long-term care, the Irish Health Information and Quality Authority recommends an interdisciplinary review of each patient on long-term medications every 3 months. So building on a systematic review of deprescribing barriers and enablers in long-term care conducted by the research team published in Age and Aging, the primary aim of this study was to generate an understanding of barriers and enablers to deprescribing in Irish long-term care facilities, providing guidance for a deprescribing intervention design. Secondary aims include a comparison of the barriers and enablers experienced by healthcare professionals representing the 2 different organisational structures in long-term care. So this was a qualitative descriptive study, aligning with the concept of pragmatism, so choosing the methods which best address the research questions. Participants invited to the study were healthcare professionals, so general practitioners, nurses, or pharmacists who were actively involved in the care of older adults, residents in long-term care. Stratified purposive sampling was used, was the strategy chosen for this study, and long-term care facilities were stratified based on their organizational structure. Data was collected using Microsoft Teams, as this research was conducted during COVID-19. And the topic guide is informed by the theoretical domains framework by Mitchie and colleagues, and the TDF-informed deprescribing framework, which was published by the research team, as mentioned. Data was initially analysed inductively following the steps of reflective thematic analysis as identified by Braun and Clark, and all barriers and enablers identified were then mapped to the TDF-informed deprescribing framework, as previously mentioned. The data was further analysed to identify differences in the opinions of healthcare workers working in different healthcare settings. So following data collection and looking at the results, 26 interviews were conducted in total with the average interview length of 24 minutes. You see the breakdown of the different healthcare professionals here, and through inductive analysis, 38 teams relating to barriers and enablers to deprescribing were generated. All teams mapped to the deprescribing framework previously mentioned. The dominant barriers and enablers mapped to 5 TDF domains, and findings from this study were organised at the level of the domain, and the majority of dominant domains provided evidence of both barriers and enablers, and you can see the 5 dominant domains here. So looking at the dominant barriers, the first barrier was insufficient procedural knowledge. So despite an awareness of the term deprescribing and its definition, healthcare professionals did not feel equipped with the knowledge, understanding, and practical experience of deprescribing. The second barrier discusses the long-term care environment and how healthcare professionals perceive that this would affect their engagement with deprescribing. So healthcare professionals note a lack of resources to support their engagement, including insufficient time, staff, and IT. Secondly, the communication and collaboration between healthcare environments is believed to be fragmented. For example, the communication between hospitals and GPs is reported to be poor and limited, restricting healthcare professionals' ability to make deprescribing decisions due to lack of information and indications. The third barrier documents an established hierarchy, which is perceived to exist in Irish long-term care facilities, where GPs are believed to hold a position of authority compared to pharmacists or nurses. And this is identified as a barrier for those healthcare professionals as they didn't feel empowered to make deprescribing suggestions to GPs. And then the final barriers identified are also social, and they discuss the negative social pressures and perception of deprescribing from other stakeholders. Healthcare professionals experience pressure from colleagues who prefer to maintain the status quo and avoid potential negative outcomes. Similarly, patient representatives' limited understanding of deprescribing and belief that deprescribing was a removal of care was also perceived to be a social barrier. On the contrast, healthcare professionals identified numerous enablers which would facilitate their engagement. Healthcare professionals felt that further knowledge, education, and practical experience would afford them the confidence to engage with deprescribing. Looking at the environment, organizational structures were deemed important to support engagement with deprescribing, such as introducing policies to coordinate medication reviews with a multidisciplinary team approach. Social factors were also identified, and examples include positive social influences and support from other healthcare professionals and engaging patients themselves in the process to get their buy-in. In addition to established enablers, which currently exist in some settings, healthcare professionals identified a range of potential enablers which they felt would support their engagement with deprescribing if they existed. So firstly, educational opportunities for deprescribing was widely documented. Secondly, healthcare professionals, both with and without experience of deprescribing, suggested that they need more tailored guidelines specific for deprescribing to support their engagement. They called for a structured deprescribing procedure to be implemented to facilitate uniform engagement with deprescribing. And finally, healthcare professionals suggested expanding the role of pharmacists to increase their scope of practice as autonomous practitioners. This included the need for pharmacists to be on site at long-term care facilities with access to patient notes, providing clinical knowledge to GPs and supporting decision-making. So looking at the secondary aims, we conducted a comparison between the two healthcare professionals from the two organizational structures, and it appeared a greater number of barriers existed for private long-term care facility workers. A greater number of these healthcare professionals reported a reduced awareness of deprescribing guidelines. they emphasized the need for incentives to support their engagement. And there was a lack of organizational commitment and deprescribing commitment among these healthcare professionals, which negatively influenced their engagement with deprescribing. So considering these results, how can we use these constructively to design a deprescribing intervention? So firstly, structures to support deprescribing already exist. Deprescribing interventions extend from the quarterly medication review by incorporating the multidisciplinary team approach, drawing on the knowledge and experience of all healthcare professionals. Educating healthcare professionals on deprescribing and how to use these tailored guidelines and algorithms could increase the level of deprescribing engagement. Increasing the roles and responsibilities of pharmacists include clinical services such as medication review and staff education could support deprescribing. And finally, some healthcare professionals believe that deprescribing decisions would not be welcomed by patients or representatives. However, by engaging with shared decision-making, patients could feel empowered to positively engage with deprescribing potentially inappropriate medicines. So overall, the study identified that the long-term care environment is an ideal setting for deprescribing. However, limited resources, in addition to poor coordination with other healthcare settings, confines healthcare professionals from successfully deprescribing. Healthcare professionals considered feasible to implement deprescribing in long-term care. However, an intervention must be designed to account for the nuanced barriers which exist in both settings. I want to thank you for your interest in our deprescribing study. If you have any questions, I would be delighted to engage. Thank you for listening.
I have no commercial relationships to disclose. The pain prevalence rate among homebound elderly is 50 to 80%. Factors associated with pain have been identified as gender, disease, and age. Home care nurses play an essential role in pain relief by selecting appropriate medications for symptoms and educating clients and families. However, the association between change in pain level and the care process of home care nurses is not clear. This study examined the association between the care process and change in pain levels among older people receiving home care. Design is secondary analysis of a one-year prospective cohort study. Participants are nurses who provided home care to older people aged 75 years and older. This study is an online questionnaire survey, and data were collected at 5 points: baseline T0, 1 month later T1, 3 months later T2, 6 months later T3, 12 months later T4. This slide is a conceptual framework. We examine the association between the care process for pain management at T0 and change in pain level at each time point. The pain scale was based verbal rating scale. Nurses evaluated clients' pain from 1, no pain, to 5, unbearable, in the past 30 days. And the change in pain level is the change of scale from baseline to other time points. The range is from -4 to +4. Plus means improvement and minus means worsening. Based on guideline, literature, and expert opinions, care process indicators were newly developed. It consists of 5 assessment items, such as monitoring the degree of pain on exertion and the impact of pain on daily life, and 6 care items, such as sharing goals among clients, family, and service providers, advice on activities of daily living. Nurses reported whether clients received these items or not. The first analysis is descriptive statistics. The second, using a t-test, we examine the association between the practice of care process at baseline and change in pain level from baseline to other time points. The third is multiple regression analysis. The dependent variable is the change in pain level, and the independent variables are care process, client characteristics, age, gender, and cancer. Next is the result. This slide is a flowchart. Among the baseline participants, we exclude those who did not use the service of home care nurses, missing data on pain level or care process. And we exclude the participants who were reported no pain to examine the impact of the assessment and care provided. From T0 to T4, we analyzed 416 to 209 cases. This slide shows the participants' characteristics. The mean age was 85 years old. About 64% were females, and 10 to 70% were cancer. Mean change in pain level were about 0.3 to 0.5 at each time point. This slide shows the percentage of care process implemented. Assessment items were implemented 78 to 95% at each time point. Care items were implemented 30 to 85%. Consultation with a physician regarding different drug treatment was the lowest at the 30% level. This slide shows the association between the care process and change in pain level. Consultation with a physician regarding different drug treatment was significantly associated with pain improvement at all time points. Sharing goals among clients, family, and service providers, and supporting to take medication were associated with pain improvement at T4. Finally, this slide showed the result of the multiple regression analysis. Our main finding is one of the care processes, consultation with a physician regarding different drug treatment, was significantly associated with pain improvement at all time points. Other care process variables were not associated with pain improvement. Next is the discussion. As I mentioned before, our study reveals that consulting with a physician regarding different drug treatment was related to pain improvement. Previous studies have suggested that reporting client situation and consulting with physicians are one of the critical roles of home care nurses. Appropriate consultation with the physician by the nurse may have contributed to pain improvement. Other care process variables are not related to pain improvement. It is essential to provide a combination of different types of assessment and care according to the client's situation. Individual examination of care items might not find the effect of combination among care process items. Limitation. It may not accurately capture the client's pain because of nurses' reports. Failure to consider the implementation of care processes of T1 to T4. Conclusion. Nurses' care, consultation with a physician regarding different drug treatment is related to client's pain improvement. More studies are needed to understand the effect of care process better. Thank you.
So good afternoon, everyone. My name is Kevin O'Malley. I'm a registrar in geriatric medicine at Galway University Hospital. And today I'm going to be talking about institutional erasure of LGBTQ older adults on the websites of nursing homes and long-term care facilities in Ireland. So just to give you a quick overview, I will provide some background information so that you have some context for this research. Then I'll talk about our aims, how we went about it, and what we found. So LGBTQ older adults have been described as an invisible minority, which is a reference to the intersection of their older age and their minority sexual and gender identity. It's estimated there's 25,000 older adults who identify as LGBT in Ireland, although the true figure is likely higher than that. And in any case, it's expected to grow in the coming years. Ireland, like many countries, has witnessed significant social change in recent decades, and nowhere is that more apparent than the trajectory of LGBT rights. However, despite that, LGBT older adults remain largely forgotten in aging services, policies, and research. So what is institutional erasure? Well, it manifests in the failure to recognize, include, and accommodate the needs of individuals outside a particular norm, in this case, a heteronormative or a heterosexual or a cisgender norm. It's usually a passive process, but it manifests through an absence of inclusive policies and practices, a lack of visual representation in promotional materials, the use of heteronormative or cisnormative language in kind of clerical forms, or in the provision of activities that segregate based on a gender binary. So for example, men's sheds or ladies' bake sales. The aim of this study was to explore the LGBTQ inclusivity of Irish nursing homes and long-term care facilities, as could be determined from the content of their websites. So we had 6 items of interest. We looked at LGBTQ inclusive symbols, messaging that directly addressed LGBTQ persons, the presence of a diversity and inclusion statement, and whether or not there was specific reference to sexual and gender identity. Then finally, the use of heteronormative stock imagery, and whether or not there was LGBTQ inclusive imagery. We identified 578 nursing homes through the Health Information and Quality Authority, and of those, 298 were suitable for inclusion. Of the facilities that were not included, the main reason was that they didn't actually have a website. Predominantly those were state-run community nursing units. So our findings are illustrated, are outlined in this table here and illustrated in the slides ahead. As you can appreciate, the results are quite stark. None of the websites that we looked at featured LGBTQ inclusive symbols, and none of them directly messaged LGBTQ persons. Only 3 of the 298 websites featured a diversity statement, and only 1 of those 3 specifically referenced sexual orientation. In terms of the stock imagery and photographs used, 58 of the websites, or just under 20%, had heteronormative imagery, compared to just 4.6% featuring LGBTQ inclusive imagery. So here's a sample of the types of heteronormative photographs that were featured on these websites. And in comparison then, the LGBTQ inclusive imagery. Of note, the LGBTQ inclusive images all comprised of female-female pairings, and this photograph in the bottom right is the only photo that depicted an actual embrace of any kind. The rest were quite platonic in their persuasion. So why is this important? Well, statistically, LGBT older adults are more likely than their non-LGBT counterparts to enter long-term care. And they do so at a younger age. There's a number of reasons for that, including poorer health outcomes, the fact that they're more likely to be unpartnered in later life and less likely to have children. The findings, our findings, and the lack of representation certainly resonates with the perception of many older LGBT adults that nursing homes are unwelcoming or insensitive to their needs. And there's a strong sense of fear of regression of hard-fought rights. So whether that's having to conceal their sexual orientation in a nursing home, or having to revert to their gender assigned at birth. Also, individuals with cognitive impairment are particularly vulnerable, where their identity is at odds with their family's wishes. So I suppose it's unsurprising then that for many LGBTQ older persons, it's important that these facilities do openly communicate and promote the fact that they are inclusive, that it's not just taken for granted or assumed that they are inclusive kind of by default. And I suppose to that end, LGBT Ireland, which is an Irish charity, have proposed the development of a quality standard award that could be governed by the Health Information Quality Authority. And I suppose it would signal to LGBT persons that particular facilities and nursing homes are inclusive and accepting and welcoming places. Just here on the screen is an example of what that could look like, similar to the Board B quality assurance mark that we have in Ireland, that this is something nursing homes could display on their websites, and it indicates them as an inclusive and accepting facility. So I suppose in conclusion, with the number of LGBT older adults expected to increase in the years ahead, it's imperative for healthcare providers to be cognizant or aware of institutional erasure as a barrier to aging well. So thank you very much for your attention.
Hello, my name is Bruno Simas da Rocha. I am a clinical pharmacist at the Hospital de Clínicas de Porto Alegre in Brazil. I'm very grateful for the opportunity to represent the team that carry out this study here on the 22nd World Congress of Gerontology and Geriatrics. And our study is entitled Association Between High Anticholinergic Risk Drugs with Incident Delirium in Hospitalized Elderly Age 75 years or older in a hospital in Brazil. To start, delirium is an acute fluctuating syndrome of altered attention, awareness, and cognition. It's very common in older persons in the hospital and long-term care facilities and may indicate a life-threatening conditions. It is a multifactorial condition, so the use of drugs with anticholinergic risks may increase the risk of delirium development. It is important to carry out identification and assessment of delirium objectively using appropriate instruments. This syndrome can be classified as hyperactive when the symptoms of agitation predominate, hypoactive when the patient has a lowered sensorial, and mixed when it oscillates between hyperactive and hypoactive. So the objective of this study is to describe the association between anticholinergic medications, other factors, and incident delirium in hospitalized elderly. For this, a retrospective cohort study was conducted in a tertiary university hospital in southern Brazil. The inclusion criteria were elderly people aged 75 years or older admitted to the hospital with at least 2 delirium evaluations. The exclusion criteria were ICU admissions. Incident delirium was considered when the elderly had a positive short CAM score in their second evaluation. The short CAM is a scale that assesses aspects of attention and behavior systematically applied in our institution by our nursing team. The anticholinergic risk scale used was adapted from Rudolph, who scores anticholinergic drugs at 0, 1, 2, or 3 points, with the prescription of each of these drugs being combined together, which can lead to a final score from 0 to greater than 3 points. For the statistical analysis, associations were performed between incident delirium and the related variables. When there was a statistically significant association, the estimate of odds ratio was adjusted for age, anticholinergic risk, and cognitive impairment. So these are our main results. A total of 165 patients were hospitalized in November 2020, the month evaluated, with an average age of almost 82 years and 10.5 drugs prescribed at admission. Among the patients evaluated, 109 had at least 2 short-term assessments with almost 12% incident delirium on hospitalization. As you can see in Table 1, which presents the general characteristics of the sample and factors that may be related to delirium, death, prior cognitive impairment, active infection, and device use, like nasoenteral tubes, strains, and catheter, were not associated with delirium. However, age was statistically significantly associated, with the incidence of delirium being higher in older adults with a higher mean age. Table 2 presents drug data and anticholinergic risk association with delirium. It is possible to verify that the incidence of delirium was higher in the elderly with the highest number of medications, as well as the highest mean anticholinergic risks. It was possible to observe that incident delirium was associated too with elderly patients with a very strong anticholinergic risk prescriptions, with a score of 3 or more points. Figure 1 shows the most prescribed anticholinergic drugs in our patients. It was metoclopramide, opioids like morphine, tramadol, and codeine, and antipsychotics like haloperidol and quetiapine. There was only a statistically significant difference in proportion of prescriptions in patients with incident delirium in red for haloperidol and quetiapine. So in conclusion, it was observed that death, prior cognitive impairment, active infections, and device use were not associated with delirium in our study. Hospitalized elderly with higher age and number of drugs prescribed, high anticholinergic risk, and prescriptions with a very strong anticholinergic risk score of 3 points or higher have a higher risk of developing the delirium during hospitalization. These factors support the design and implementation of multi-component interventions for the prevention and management of delirium, such as pharmacotherapy review and drug prescribing, especially on prescriptions with high anticholinergic risks. Once again, I appreciate the opportunity to share our study, and I am open to discuss and answering your questions. Thank you.
I have no commercial relationships to disclose. There are global demands for building dementia-friendly communities. The effective approach are reported to have dementia educational activities for the general public. The dementia training program is the most popular dementia educational program for the community resident in Japan, but it is inadequate in developing helping behavior. So it is necessary of educational activities to generate helping behavior for people living with dementia. Virtual reality technology enables us to experience first-person perspective and generate helping behavior. Previous VR-based dementia educational program improved attitude and knowledge. However, there are several limitations of existing research. There are few studies with 2 groups and shortage to promote helping behavior. So we developed the VR-based dementia educational program to experience first-person perspective to promote helping behavior. Research aim is to examine the effectiveness of the dementia educational program using real technology regarding attitude, intention of helping behavior, and knowledge of the general public toward people living with dementia. Research design is a randomized controlled trial. At the intervention group, participants attend the dementia educational program using real technology. At the control group, they participated in lecture-based dementia training program. Participants are to be over 60 years old, have never attended a dementia training program. Research period, location, and ethical consideration are as described. Randomization was performed for each program individually. Data collection procedure is to submit informed consent, respond pre-test, attend each program, and to respond post-test. This program was based on the instructional design theory. The goal of this program to understand dementia precisely, improve attitude, and facilitate active learning. There are 5 elements of the intervention program: simulation, short film, real film, lecture, and discussion. At the control group, only the lecture was provided. At the intervention program, the first session is simulation, demonstrating a fictional situation wherein the PLWD had a problem participants discussed. Secondly, in a short film, viewing the story regarding an older woman living with dementia, participants can learn the appropriate communication from the scenarios. Thirdly, in the real films, participants experience a first-person perspective of female PLWD through the situation dementia symptoms. Furthermore, participants attend a lecture about dementia symptoms and appropriate communication. Finally, in discussion, participants exchange their impression after viewing films and participate in a role-playing game. As a primary outcome, we used attitude toward PLWD. A higher score indicates a more positive attitude. As secondary outcomes, we used intention of helping behavior and knowledge of dementia. Covariates are age, gender, experience of helping older adults, and so on. For estimation of statistical power, as described, the estimated sample size was 68 participants for each group. For statistical analysis, we examined the homogeneity of the baseline participants' characteristics between two groups. To compare the changes in the outcome from T1 to T2 between two groups, we used student t-test and estimated effect size. A total of 157 people were assessed for eligibility, but a total of 12 people were excluded. A total of 145 people were randomized and allocated to each group. A total of 62 people received the intervention groups program, and 68 people received the control groups program. The mean age of total participants was 64 years old. The percentage of female was 71. The percentage of people who experienced helping older adults was 65. Baseline scores of the outcomes were not significantly different between groups. In the attitude score between two groups, it was no significant difference, but the intervention group score was more improved. In the attitude score in pre and post-intervention, the significant differences were observed in both groups. In the intention score, the intervention group score was more significantly improved than the control group. On the contrary, in the knowledge score, the control group score was more significantly improved than the intervention group. From the result, there is no significant difference in improving attitude toward PLWD between two groups. Regarding the effect on attitude toward PLWD, the significant improvement in the attitude score were found in both groups. It would indicate that both programs are potentially effective to promote attitudes to community residents toward PLWD. Regarding the effect on intention of helping behavior, the improvement was significantly larger in the intervention group than the control group. This PL program might be more effective in invoking the intention of helping behavior across the actual helping behavior than the lecture-based program. Limitation of this study are generalizability of the result is limited. Effects of individual components of the program are unclear, and the long-term effect of the intervention should be investigated. In conclusion, the real-based intervention significantly improved the intention of helping behavior than lecture-based program. Thank you for your listening.
Hello to everyone. I invite the public to do any questions you want. And I'm going to start doing some questions to, for example, Karen Boyans. I want to ask you, I think it was a very interesting job. And I want to ask you if you have investigated about drug abuse in these offenders that you interviewed.
Thank you, Dr. Barrett. We have investigated and looked into the lifestyle of the older inmates before incarceration, and which included drug and alcohol abuse, and then also if they do use drugs during their period of incarceration. And interesting enough, we found that the offenders from our research group indicated that they did use alcohol as well as cannabis prior to incarceration, but not on a regular basis. And during incarceration, they indicated that they do not use cannabis, which is freely available in South African correctional services, which is an interesting finding. And we think that maybe some of the respondents withheld information because they were afraid that maybe we can connect them and their answer and report them to our correctional correctional officials. So we did briefly look at the use of alcohol and drugs prior to, and then the use of drugs during incarceration, but not a lot of the offenders came forward and admitted to the use of drugs and alcohol.
Okay, and why? What was the reason why they were victimized? Because of age?
We found the reason that they are mainly victimized because of their age, so they are seen as vulnerable and also frail, and then also, as I've indicated, their social standing in our prisons. So in our prisons, to be regarded as a man, as a macho man, you have to display, your manliness, and also younger offenders. So our older inmates tend to be victimized because of these two reasons: their social standing, and also they are perceived as vulnerable and weak.
Okay, thank you. I was thinking that now prisons must have more caregivers, no, for these aging offenders.
Thank you. Yes, definitely more caregivers, more correctional officials, and specifically trained to deal with these elderly offenders.
That's great. Now a question for Hanako Numata. This home care that you did was only by nurses, no medical doctors.
Yeah.
Okay. I think it was interesting, this item that you monitor the degree of pain on exertion. No, that is original for me. I think it was very interesting.
Thank you.
Great. And now a question for Haruno Suzuki. I think that this work you did to promote dementia-friendly communities, no? It's like a great initiative for getting this type of communities. And I wanted to ask, what do you mean by helping behavior with this intervention?
Thank you for your question. The intention of helping behavior means the idea or the concept to helping the people living with dementia. For example, the general public encounter people living with dementia in the community, and they will decide to help for them or not, such as guiding the way or the something giving help. So it means so we cannot measure the helping behavior in this study. So we we measure the alternative outcome for in this study.
Okay.
Study. So we we measure the alternative outcome for in this study.
Okay, thank you. Now, a question for Bruno Rota. I think it was very interesting what you have studied, and this would be what you studied would be the iatrogenic delirium, no? By these high anticholinergic drugs that were given to the patients when they were hospitalized, no?
Yes, and the scale we use, that is short CAM, it doesn't have the cause of delirium, but with our work, we could associate the high-cholinergic risk medication with the delirium incidence with the short scale for delirium. So it is our hypothesis and is for the delirium incidence. So we didn't consider the medication used at home, for example. So it was in the second measure of the short cam. So it was not when the patient entered the institution, but the second measure. So probably it was because of the medication used in the hospital.
Perfect, great. And the question for Laura, in Spanish. En este trabajo que ustedes hicieron, ¿pensaron en alguna intervención para abordar el aislamiento y la soledad?
Sí, intervenciones varias, gracias por la pregunta. Intervenciones que tienen que ver fundamentalmente con instalar lo que implica desde las comunidades, los barrios y los lugares más cercanos a aquellos adultos mayores, tanto independientes como con diferentes inconvenientes, porque también hay que pensar en aquellos dependientes, la posibilidad de generar eventos grupales que tengan que ver con reconectarse nuevamente con la posibilidad de encontrarse menos aislados, más conectados, intervenir con aquellas familias que quizás no estén tan cercanas como debería ser. Hay toda una cantidad de herramientas para poder tratar de acercar a las familias, a aquellos familiares e incluso a aquellos voluntarios. Quiero destacar esto porque en Perú hay un movimiento de voluntariado muy importante y muy interesante, el cual puede reclutarse realmente para formar parte de todo lo que es acercarse a estos adultos mayores que viven en aislamiento, más allá de los aspectos psicológicos o psiquiátricos que necesiten en caso de tener que ser abordados. Espero haber respondido a la pregunta.
Sí, sí, perfecto, muchas gracias.
No, al contrario, gracias.
Okay, well, there are missing 3 speakers that had also very interesting abstracts, but I invite you, if you have any question to other speaker, to do it. I think if you don't have any questions, I think that all the abstracts were very interesting. They invite us, the different works, to be more aware, no, about the loneliness, about dementia, about discrimination, and the awareness is the first step to change something. So I think all these investigations will help us to improve policies and the well-being of older adults. Huh? So we're in time. Thank you to all for all your expositions. Bye.